Totally agree. So I thank you so much again for your very nice presentation, Odd. And it's time to move on to another crucial and very debated issue. And it's time to introduce Professor Fabio Piscaglia, who will talk about CEUS in hepatocellular carcinoma evaluation. Just a few notes about Professor Fabio Piscaglia. He's associate professor in internal medicine in Bologna, past president of EPSUM, and he is one of the leaders of ultrasound who is contributing with an outstanding contribution to the literature, and he publishes several papers, mostly on hepatocellular carcinoma. So it is a great pleasure and an honor to introduce Fabio, who will talk about hepatocellular carcinoma. Please, Fabio.
Thank you very much, Vito, for your kind introduction. I put some more light as I've been showing, and we can move on. I hope you can see my screen. And so we will talk about now the contrast-enhanced ultrasound in hepatocellular carcinoma. Clearly, we have to start from focal liver lesions, and CEUS is applied to characterize them, and finally, in several cases, to establish a diagnosis of HCC. What sort of lesions can we meet in the daily life? What sort of lesion emerge during the surveillance of patients at risk of hepatocellular carcinoma, which are mainly patients with established cirrhosis, regardless of the etiology, or patients with advanced severe fibrosis, male with hepatitis B chronic infection. As you can see in these slides, most cases emerged during surveillance in cirrhotic patients. Nearly 80% of these nodules were hepatocellular carcinoma, a final diagnosis, whereas a few others were either dysplastic nodules or hemangioma or borderline lesions. If we move to other series like these two, this one and this one, collected in Barcelona and Bologna, in Barcelona and Milan, which are two other quite famous centers in the management of liver cancer, you can see that in lesions beyond 2 centimeters, between 1 and 2 centimeters, about 2/3 were HCC, both in Milan and in Barcelona, whereas most other lesions were regeneratively dysplastic nodules, and very few were cholangiocellular carcinoma. Approximately 1 to 2% of all new lesions in cirrhosis are cholangiocellular carcinoma. So you can see from here that we have a rate of probability that we can summarize here. If these lesions are between 1 and 2 centimeters, about 2/3 are hepatocellular carcinoma. If the lesion is bigger, between 2 and 3 centimeters, 85% are hepatocellular carcinoma. If more than 3, 90 to 95% are hepatocellular carcinoma. If this is not the case, the remaining instances are, in the large majority of cases, regenerative nodules with or without dysplasia, or very rarely either hemangioma, cholangiocellular carcinoma, 1 to 2%, lymphoma, metastasis, or other extremely rare exceptional entities. So in the daily life, when we see a lesion in cirrhosis, we have to start from the idea that this most likely is an HCC, and maybe we can confirm that this is the case by imaging, and if not an HCC, we have to differentiate between these other lesion types. When we see a hyperechoic, well-defined lesion in an otherwise healthy liver, we are able, in most cases, to establish a diagnosis of simple hemangioma. Does this stand true also in cirrhosis? You can see here a large number of consecutive patients with cirrhosis who were detected at the first ultrasound scan with focal liver lesions in 44 cases. These lesions were hyperechoic, hemangioma-like. The final diagnosis obtained by imaging and biopsy was indeed hemangioma, but only in half of the cases, whereas the remaining half of the cases, despite appearing like hemangioma, were instead a hepatocellular carcinoma. This was the case when these lesions were detected concurrently with the diagnosis of cirrhosis. But if the patients were under ultrasound surveillance for lesions, so this means that they were known to have cirrhosis, but with no focal lesions, and the lesions developed during surveillance, then in these cases, which was 26 lesions, you can see that nearly all of them were HCC, and all of them anyhow were hepatocellular lesions with no hemangioma. So this means that if we detect a lesion hyperechoic resembling hemangioma in cirrhosis, if this has been detected at the time of cirrhosis, it might exist since many years, so in half of the cases is hemangioma, but don't stop your imaging workup because half of them are already malignancy. And if the lesions was not there before and is new, then in nearly all cases it is not a hemangioma but a hepatocellular lesion, most likely an ACC. So the first slides showed us that it is not possible to establish a diagnosis of malignancy or even of benign focal liver lesions in cirrhosis with conventional ultrasound. So what is the addition of contrast-enhanced ultrasound? Among the different abnormalities that contribute to make a normal cell a cancer cell and a cancer tissue, there is also the neoangiogenesis, the proliferation of abnormal vessels. And this is something that can be explored by adding contrast to conventional ultrasound. These slides, produced by Japanese colleagues, displays very nicely what happens to the abnormalities of vascular perfusion to focal liver lesions. These Japanese colleagues submitted patients to CT during angiography, at first by injecting contrast only in the hepatic artery, thus assessing only the perfusion supported by the artery in focal liver lesion. Then they withdrew the catheter, inserted it in the splenic vein, injected. So through the splenic artery, splenic vein, portal vein, they could show the perfusion only supplied by the portal system. And they could show the behavior of the portal system. All these lesions were submitted to surgery, some maybe because there was an HCC as well, but they dissected together a nearby lesion. So the authors were able to show the true arterial and portal vascularization in lesions submitted to a final diagnosis by histology after resection. So what we can see here is that in large regenerative nodules, the perfusion is like in normal livers, about 1/3 by the artery, 2/3 by the portal vein. As the progression of transformation of large regenerative nodules to low-grade dysplasia, high-grade dysplasia, early hepatocellular carcinoma, well-differentiated hepatocellular carcinoma, and classical hepatocarcinoma proceeds, you can see that there is a progressive decrease in the portal venous supply to the nodules, while at the same time there is a progressive decrease in the normal hepatic artery, the paired artery, to the nodules, while at the time of transformation of regenerative nodules into cancer, there is the appearance of the neoangiogenic vessels. And at a certain time, the degree of extent of these new vessels is so high that it surpasses the normal surrounding parenchyma in terms of arterial supply. And when this happens, we can see these lesions as with an excess of enhancement in the arterial phase, and this is what defines hyper-enhancing or hypervascular lesions that, as you can see here, occur in case of hepatocellular carcinoma, while these rarely occur at the transition between high-grade dysplastic nodules and hepatocellular carcinoma. At the same time, these slides show that there are some malignant lesions which do not have yet developed the hypervascular appearance, and these are called the hypovascular HCC. Not all of them are truly hypovascular, less arterial enhancement than the surrounding parenchyma. Some have the same enhancement as the surrounding parenchyma, but any lesion, any malignant lesion which is not hypervascular is called in practice hypovascular HCC. So please keep this scheme in mind, and we will understand very well the behavior of the various nodules. The possibility to establish a diagnosis of hepatocellular carcinoma by imaging only, which is peculiar only for this cancer, because in no other cancer it is possible to establish a cellular lesion. If we have a lung lesion, we can say this is a tumor, but clearly it is not possible by imaging alone to tell whether there is a small cell or not a small cell cancer, just to make an example. In the setting of cirrhosis, imaging alone is now accepted to establish a diagnosis not only of malignancy, but of hepatocellular malignancy, namely of HCC. And this has been accepted since the year 2001, following this consensus conference held in Barcelona, where also Italian authors like Massimo Polombo, Luigi Pagliaro, and Luigi Bolondi, Riccardo Leccioni, participated. So at that time, the possibility was produced to establish a non-invasive diagnosis in nodules more than 2 centimeters by angiography, CT, MRI, or Doppler ultrasound. 2 of these lesions showing hypervascularization of one of these techniques, sorry, not lesion, and elevated alpha-fetoprotein. So you may wonder why is, and this could produce a diagnosis of HCC. Why is not CEUS there? Simply because at that time, real-time CEUS was still not available, so it could not be in the first guidelines. From 2002, CEUS was introduced in the clinical practice, and it showed the same pattern that was showed until then by CT or MRI, which is hyper-enhancement, global, homogeneous in the arterial phase, followed by washout, and washout corresponds to the lack of the portal contribution, mainly in typical HCC. However, I will touch this point later, a number of HCC do not wash out in the late phase. So this is the typical appearance. Hypoechoic lesion in cirrhosis. In the arterial phase, 29 seconds in this situation, hyper-enhancing, and then mild washout in the late phase. Mild means that you see this area is only slightly hyper-enhancing in comparison to the surrounding parenchyma. If you have in mind the metastases, they do look much more black, darker than these lesions 2.5 minutes after contrast injection. This is an example to show the progression of the neoangiogenesis. This was a small lesion in a patient with hepatitis B related cirrhosis. He had several lesions, 3 others were biopsied and were high-grade dysplastic nodules, and this one was not biopsied because of the difficult location. So we waited, and 3 months later he had this enlargement, and you can see that there is tiny, slight hyper-enhancing. This lesion could not be treated by percutaneous ablation because of the location, and was attempted to be treated by TACE, but yet a dissection of the artery could not be treated, so it was put on the waiting list. While waiting for transplantation, there was an increase in size, and you can clearly see that there is also a progression of the neoangiogenesis, and finally, and likely, he was transplanted. It is still very well doing. But you can see the progression for mild hyperenhancement to clear hyperenhancement in a few months. And this is what happened. March 2015, progression from a slightly or iso-enhanced, slightly hyperenhancing to a frank hyperenhancement. Sorry, this was at the beginning, before the hyperenhancement, slight hyperenhancement, and clear hyper-enhancement. Clearly, we do not want to see the natural progression. We will treat the lesions, but in this case, it was not possible to treat it, and so we could see what happens. Ultrasonography has a very high spatial resolution, so in very well explorable livers, also contrast-enhanced ultrasound can depict very tiny nodules. You can see here, this lesion is very well detected by CEUS as arterially hyperenhancing. You can see that the portal vein is still not perfused because this is the purely arterial time, while also a smaller lesion can be depicted here that I did not see on conventional ultrasound, but after looking at this image, it is possible to see it here. So real-time CEUS has a very good spatial and temporal resolution. One of the situations that we may meet and which allows us to make a diagnosis of HCC is the growth of a clone of malignant lesion within a dysplastic lesion. You can see here this lesion, about a bit more than 2 centimeters, is truly hypo-enhancing in the arterial phase and does not wash out in the late phase. If you remember the columns, this is one of the truly hypovascular lesions, and we know that it might be a cancer or still can be a regenerative dysplastic nodule. So this lesion was biopsied, and it was a regenerative dysplastic nodules. So this patient was low-grade dysplastic nodules. He had a poor liver function, so he was put on follow-up. And about 9 months later, the lesion did not change. It was still hypovascular in the arterial phase and iso-enhancing in the late phase. But some months later, it was that was about 15, 19 months later, you can clearly see a hyperechoic foci within the hypoechoic lesion. And if you go with contrast enhancement, you can see that these two parts of the nodule, which is called the nodule in nodule, do behave differently. The larger lesion, which is a regenerative nodules, is still hypovascular, whereas this other part has become hyper-enhancing in the arterial phase, and this part does wash out in the late phase. So we clearly see that the inner nodule has become a malignant lesion, a hepatocellular carcinoma, grown within a regenerative nodules. So we believe that these patterns are very well shown, particularly by ultrasound and by contrast-enhanced ultrasound, because this technique can be repeated quite often, differently from CT or MRI. This is a typical hyperenhancing. You can see the lesion here and the global hyperenhancement of this lesion in the arterial phase. So this is what we call the typical hypervascularity of HCC. As I mentioned, there are hypovascular nodules. I've shown you one. This is another example, clearly hypo-enhancing in the arterial phase, rapid filling, and iso-enhancement in the late phase. This might resemble a hemangioma, but here we don't have the globular enhancement pattern, and over time, differently from the hemangioma, this pattern changes. And you can see that 4 months later, the patient could not come earlier because she fell and broke her femur, so she came only 4 months later. She was an elder lady. This lesion that was hypovascular has become nearly completely hypervascular, despite it still does not have washout. So it has passed from this area of hypovascularity to this part of hypervascularity, but still preserve some portal venous supply. So clearly we are not able to establish a final diagnosis for this lesion because it does not wash out. It might still be a dysplastic nodules or most likely a hepatocellular carcinoma, but this does not fulfill the typical pattern, which is hyperenhancement plus washout. As I mentioned, some HCC lack arterial hypervascularity. May we relax and just say to these patients, please come in 3 months and we will see what happens if biopsy is possible? No, it is important to establish a rapid diagnosis, so to perform biopsy, because these hypovascular HCC do behave as aggressively as those that are already hypervascular. And this statement that I've told you has been demonstrated by this recent article appeared this year in Journal of Hepatology, which showed that the lack of arterial hypervascularity at contrast-enhanced ultrasound does not define priority. So it means that you cannot wait. If you don't reach a final diagnosis of HCC and you have a hypovascular nodule, you are not allowed to wait. You have to try to reach a final diagnosis by performing a biopsy, because some of these lesions, about 20%, are already cancer. This is the detail of all lesions that were hypovascular in the arterial phase, and by hypovascular, I recall this might be either truly hypovascular or only lacking arterial hyperenhancement, so they were iso-enhancing in the arterial phase. So as you can see here, some of these lesions were iso-enhancing, and iso-enhancing, and they lacked hyperenhancing also MRI. So this means they were truly hypo-enhancing lesions, but nonetheless they were tumors. They were well-differentiated tumors, and some of them did recur over time, suggesting that they have to be treated as aggressively as the other lesions. We have talked about the hyperenhancement in the arterial phase. We talk now to the venous washout. This is very important to define with certainty that our lesions are malignant, because as you can see here, the washout is due to the complete disappearance of the portal vessels, and this appears frankly and totally only in case of moderate or poorly differentiated HCC, according to the scheme of the Japanese authors, whereas some of the portal vessels still are preserved in the early tumor stage of HCC. Does this reflect the clinical appearance? The answer is yes. The washout, as you can see here, is mild, and it occurs late. Late means that it does not appear before 60 or usually 90 seconds. If it appears early, we should think about something else. And as you can see here, is very mild. This is typical for HCC. This study investigated lesions found during intraoperative ultrasound for resection for HCC, and studied the nature of the additional lesions that were seen. When the pattern was typical, some hyperenhancement in the arterial phase plus washout, nearly all of them were finally HCC, as you can see here, and only few were regenerative nodules if they had not a full-blown arterial hypervascularity. But when only washout is present, which is a hypovascular lesion, may this be already HCC? We already said yes, and this study confirmed that even in very tiny lesions, about 40% are already HCC. But if they're not HCC, imaging is not able to define the nature, because some of them were regenerative nodules, some were biliary hamartoma, and one was a necrotic lesion. So it is impossible to make a final diagnosis, and biopsy is recommended. In case of iso-enhancement of very small lesions in the short follow-up, this author did not find any tumor, but these were all very tiny lesions, less than 10 millimeters. As I've mentioned, not all tumors, not all HCC do wash out, and indeed the typical pattern, which is arterial hyperenhancement plus washout, is not found in all HCC. In these studies, the typical pattern that I mentioned was present in 50% of these nodules up to 2 centimeters, 42% in our study, 22% in these tiny nodules in another study. So you can see that the sensitivity of the typical pattern for tiny nodules is not very high, 20 to 50%. But this is true also for MRI and CT. MRI 44%, CT 53%, because in tiny nodules, the neoangiogenesis is not yet full-blown. So this is not a pitfall of CEUS, but is a limitation of all imaging techniques. What you can notice here is that CEUS in all series was slightly less sensitive than CT or MRI. Why is this? It is not because CEUS is not sensitive to hypervascularity, but it is because CEUS is less sensitive to washout. This depends on the type of contrast agent that is utilized, and because this is more related to the type of portal vessels lack. And in fact, the lesions that have hyperenhancement but do not have washout, they tend to be well differentiated, whereas those that have hyperenhancement plus washout are usually more poorly differentiated, either moderately or poorly differentiated. And this has been confirmed by 4 different studies. All of them said the same thing. And one was a prospective study with biopsy of all nodules. So this is totally confirmed, and this could be utilized because the degree of differentiation is related to the prognosis. If we see the typical pattern hypo at CEUS, the positive predictive value for hepatocellular carcinoma is extremely high, 98%, and in patients who already had an HCC cured, it is 100%. If we take only hypervascularity, there is only a minor decrease of the sensitivity. The presence of washout can be assessed in doubtful cases also by CEUS quantification. And I would like to recall that if the typical pattern is not present, like in this case, eyes enhancing the arterial phase, no washout, biopsy is needed. So with this background, CEUS was introduced in the guidelines for the management of HCC in 2005. These are the American guidelines. You can see here that contrast ultrasound is accepted when it shows the typical pattern, hypervascular plus washout. However, in 2010, this additional manuscript shows that the same pattern is presented also by cholangiocellular carcinoma. So this means that there might be a risk of false positive diagnosis of hepatocellular carcinoma when instead a cholangiocellular carcinoma is present. This is not the case in all cholangiocellular carcinoma. Only 10 out of 21 presented the typical HCC pattern, while the remaining ones a different pattern and mainly rim enhancement. Differently from CEUS, MRI does not show the typical hepatocellular carcinoma pattern, but does not show washout. So it's not even able to establish a diagnosis of malignancy. And thus, a biopsy is recommended, but biopsy is not always possible. So this is a critical point. And because of this potential risk of misdiagnosis, both the European and the American guidelines released in the last 4 to 5 years have removed CEUS. So you can see here that apparently in these guidelines only MRI or CT are accepted. These are the American guidelines and these are the European guidelines. The fact that cholangiocellular carcinoma may behave like the hepatocellular carcinoma is indeed true. This is an Italian multicenter study which showed that hyperenhancement plus washout indeed occurs in about 50% of the cases. However, what is important to note is that in the portal phase, so it might correspond to a sort of early appearance, most of these lesions are already hypoenhancing, while usually hepatocellular carcinoma shows the washout only later. And if we go back to the Barcelona series, you can see that also in this case, the majority of cholangiocellular carcinoma did wash out quite early in the portal phase. So before 2 minutes, they were already black. So today, can we still hold as diagnostic for HCC the hypervascularity plus washout? According to the FSUMB, and the WFUM, the European Federation and the World Federation and other societies, including the International Contrast Ultrasound Society, this pattern is to be held typical for hepatocellular carcinoma, but just with a word of caution that when the washout occurs rapidly before 60 seconds or it is very marked, then you have to keep in mind that it might be the case of peripheral cholangiocellular carcinoma. This is the position expressed in the guidelines released in 2013. So this example, the washout occurs early. This is the portal phase. Late phase, it is very marked dark. In this case, you have to raise the suspicion of cholangiocellular carcinoma. So you would need to recommend an MRI, and if MRI does not show the washout, then this is most likely a cholangiocellular carcinoma and needs to be submitted to biopsy. And indeed, this case was a cholangiocellular carcinoma. The fact that cholangiocellular carcinoma tend to wash out early was confirmed by a few studies. This study does not say how much were on cirrhosis. They were mainly large nodules. It was a large number of cases, hepatocellular carcinoma, intrahepatic cholangiocellular carcinoma, and you see that the start of the washout was much more late in HCC than in intrahepatic cholangiocellular carcinoma, and these were large lesions which tend to wash out earlier. If we go to smaller lesions, this is a very recent paper published in Ultraschall showing that in smaller lesions with a mean size of 5 centimeters with global enhancement, like the one that we see in hepatocellular carcinoma, all of them potentially at risk because of underlying chronic liver disease, you can see that the median time to wash out, the median time in the global enhancement was 43 seconds. So this means that 50% of the cases already showed washout at 43 seconds. So nearly all of them were already black before 1 minute, which does not occur in hepatocellular carcinomas. So this is a potential new clue to differentiate hepatocellular carcinoma from cholangiocellular carcinoma. So as I showed you, and I go back to this slide, for characterizing liver lesions in cirrhosis, we don't look at the late phase at first, but first we look at the arterial phase, and we start from saying, is it hypervascular? Yes. Then we look at the washout, and we can say whether it is in HCC, and this is the case for late and mild washout, or if it is not in HCC. If it does not wash out, which is not shown here, you need to perform a biopsy, because as I've showed you, most of these are HCC, but not all of them. Clearly, you perform biopsy only if MRI or CT do not confirm hepatocellular carcinoma. If there is no arterial hyperenhancement, then what are we in front of? It might be a hemangioma. This is one example in cirrhosis. You see a progressive filling of this lesion which becomes hyper-enhanced in the late phase. Clearly, this is highly suggestive for hemangioma, but in the setting of cirrhosis, my personal opinion is to always confirm with MRI and with pre-contrast acquisition that this is an hemangioma, because the risk of cirrhosis, the risk of cancer in cirrhosis is too high to rely on only one technique. However, this is very rare. In most instances, after lack of arterial hypervascularity, the lesion might remain iso-enhancing. No hyperenhancement, no washout, or hypoenhancement and progressive filling with iso-enhancing in the late phase. These lesions have to be biopsied, if possible, technically, because they might be, in 20% of the cases, already cancer. Sometimes the lesions do not remain iso-enhancing, but they do show washout. If the washout is quite late and only slight, then it raises a suspicion for hepatocellular carcinoma, the hypovascular hypocellular carcinoma. You can see here 1.5 minutes only minimal hypo enhancement. It becomes more evident at more than 3 minutes. Mild washout in this case. These have to be submitted to biopsy because these are also indeterminate. At last, if the washout is very marked and early, like this case, you can see that there is no hyperenhancement and the lesion becomes really very, very dark, already at 2.5 minutes. In this case, we have to think also about non-hepatocellular malignancy, like metastasis or cholangiocellular carcinoma. And indeed, this case was a mixed hepatocellular cholangiocellular carcinoma. So if MRI and CT do not solve the issue, which is most of the instances the case, biopsy is required. So to summarize, the overall rate of intrahepatic cholangiocellular carcinoma is low, but because of this presence and similarity to some HCC, it was removed from some guidelines, but it was not considered that there is a typical, a particular pattern which is early and marked washout, which tend to suggest cholangiocellular carcinoma. Moreover, CEUS may be subject to the misdiagnosis of one tumor with the other, but is not wrong in telling that this is a cancer, while MRI and CT are not able to provide a diagnosis of malignancy. So the mistake might be even bigger. So the suggestion is to combine CEUS and MRI or CEUS with CT, because in this case, CEUS is able to tell this is a malignant lesion, and if there is a rapid washout at CEUS, but no washout in MRI or CT, then we have a strong suspicion of intrahepatic cholangiocellular carcinoma. So finally, CEUS is helpful in this setting, and this is a sort of summary of what I tried to explain when to use or not to use CEUS in this setting. So when not to use CEUS, when the local expertise is still limited, when there are multiple nodules, potentially HCC, to be investigated at the same time, because CEUS has to look only in the same region during the arterial phase, because the hypervascularity is visible only for 5-10 seconds, or when the liver ecotexture is very coarse and no nodule is clearly visible, then there is no indication for CEUS, and when the liver explorability is poor. Instead, CEUS is very useful when CT or MRI are contraindicated, or when the first detection of a nodule is seen as ultrasonography in an expert center able to already perform CEUS, because it can be speed up the diagnosis of malignancy. We can immediately have an idea of how big is the probability of hepatocellular carcinoma, or potentially to establish the final diagnosis. I'm not talking about portal vein thrombosis, but CEUS is a very good technique, probably the best technique to characterize intrahepatic portal vein thrombosis. Or CEUS is useful when CT or MRI are inconclusive, especially when they miss the wash-in, because thanks to the real-time modality, CEUS might pick it up. Or in hypervascular lesion in the arterial phase lacking washout at MRI and CT. As I've just explained, CEUS might be able to tell that this is nonetheless a malignant lesion, because maybe this is a cholangiocellular carcinoma. Or finally, when there are various lesions, one close to the other, and you have to biopsy one, so the one that is not typical, so CEUS is useful because it can be performed immediately before biopsy with the same technique in order to choose which nodule to be biopsied. And at last, when you have obtained a diagnosis of this flax nodule and you want to monitor the changes in perfusion over time, CEUS is clearly the most easy technique. What I've explained has been recently summarized in this draft scheme of the American College of Radiology, which I participated to produce together with Professor Dietrich as well. that tries to summarize how to report this pattern with a different probability of hepatocellular carcinoma. So you can start from a lesion. You might be sure that this is benign, for instance, a cyst or a typical hemangioma. And this is LR1, liver reporting 1 type. Or it might be clearly a malignant lesion not typical for HCC, early, before 60 seconds, or very marked washout. So we might raise the suspicion of metastasis of cholangiocellular carcinoma. And if this is not the case, combining the presence of hyper-enhancement, hypo-enhancement, so hypo-enhancing the arterial phase, or iso-enhancement, the presence of washout, and whether this is late or mild, we can come to different probabilities of hepatocellular carcinoma or to the definite diagnosis of hepatocellular carcinoma for any lesion which is more than 10 millimeter with global arterial phase hyperenhancement and washout, which occurs after 1 minute and is mild in degree. So this is a definitively hepatocellular carcinoma. In all other situations, a biopsy would be recommended, but if biopsy is not possible, at least we might say which is the probability of hepatocellular carcinoma. And indeed, several societies have maintained CEUS in their guidelines, including the Italian Society for the Study of the Liver and the World Federation of Society for Ultrasound in Medicine Biology and the European Federation. And this is the Italian Society. So I'm not touching the point of portal thrombosis, but I just mentioned that when the thrombus is perfused, it's malignant. And having said this, that I come to the conclusive slides. We have to perform, or CEUS is recommended in any lesion when MRI or CT are not conclusive, or are not readily available. Immediately after detection of portal vein thrombosis, or in patients which are not suitable to CT or MRI because of the different pharmacokinetics or contrast agents, and there is contraindication to CT or MRI. And, but this is not the topic of today, in treated hepatocellular carcinoma. I thank you very much for your attention.
Thank you so much, Fabio, for having provided us your great and long-term experience on dealing hepatocellular carcinoma. And I would like to ask you, in your daily practice, how could be defined the role of time-intensity curve to improve the accuracy of hepatocellular carcinoma?
Well, in most of the cases, the hypervascularity in the arterial phase is very clear. So there is no need for time intensity curves. I see more a benefit of using this quantification software to define whether there is washout or not. Because this is, might be quite subjective, because as I mentioned, the washout is mild, so it might be difficult to be visible. However, we recommend that this is done, if possible, immediately, and some equipments do allow this for immediate contrast quantification. However, in the daily life, when there is a doubt in these lesions, it is recommendable to perform a biopsy, which provides us some additional information. So it still remains, in my impression, not a tool for the daily life in the setting of liver cirrhosis and focal liver lesion.